Module, we're going to take an in-depth look at the non-opioids, specifically acetaminophen and the NSAIDs. So first we'll start with acetaminophen, and its indication is for mild to moderate non-inflammatory pain. Its role in therapy is self-limited conditions such as tension headaches, mild musculoskeletal pain, dental pain. It's still considered first-line therapy for osteoarthritis pain, even though it is less effective than NSAIDs for osteoarthritis pain. But acetaminophen can delay when a patient would start an NSAID and then have the long-term side effects with the NSAIDs. So that's why it's still first line for osteoarthritis. Acetaminophen is the drug of choice in pregnancy and nursing mothers. In the last couple of years, the FDA has put out some updates on acetaminophen that I'd like to go over with you. So in 2011, the FDA sent out a report saying that all products that had acetaminophen in combination with it, they needed to reduce the acetaminophen content to less than 325 milligrams. And they had given the manufacturers 3 years to do this. In 2012, despite the FDA Advisory Committee's recommendation to reduce the maximum dose of acetaminophen lower than 4 grams, the FDA decided to continue the 4 grams, which assumes no concomitant alcohol consumption. But despite the FDA ruling, the manufacturers decided on their own to reduce the maximum acetaminophen dose on their product labeling to 325 or 3,250 milligrams for regular strength and 3,000 milligrams for the extra strength. The FDA had ruled that prior to this ruling, there was 2 formulations, one for infants, which was a lot more potent, and one for children. And the FDA decided, due to several overdoses that were reported with the infant dosing formulation, to just go with one children's strength acetaminophen, which is 160 milligrams per 5 ml. And then the most recent change was that the FDA ruled that hydrocodone with an acetaminophen combination would no longer be Schedule 3 and would now be categorized as a Schedule 2 medication similar to other opioids. Acetaminophen also comes in IV formulation, and this is fairly new. It was FDA approved in 2010, and it's for post-surgical mild to moderate pain treatment requiring intravenous medicine. So in this case, the oral and the rectal route would not be a possible route for the patient, and then you would go to the IV route. It was shown in clinical trials to be superior than placebo in hip and knee replacement surgery, in post-abdominal surgery, and for fever reduction. The dose is similar to oral acetaminophen, where you can take up to 4 grams. It's given as a 15-minute infusion in the hospital setting. And the biggest barrier to this medication is that it's very expensive when you compare it to the oral and rectal route. Here are the list of NSAIDs that you may see. The ones highlighted in red are the ones that you'll probably commonly see and ones that I'd like you to focus on. So the NSAIDs, their indication is to lower fever, to treat mild and moderate pain that may be inflammatory in nature. Its role in therapy is for acute and chronic pain. It is designated as opioid-sparing effect. That is, if you add an NSAID to an opioid regimen, you can get a lowering of the opioid consumption because this would be an adjuvant analgesic. The biggest barrier for NSAIDs is its long-term side effects. And there's a long list of them, so I'll go over with you. Gastrointestinal side effects, which include GI bleeds, GI ulcers, renal complications, platelet dysfunction, so decrease in your body's ability to clot, so more likely to bleed, cardiac toxicity, and we'll talk about this in a little bit more detail, bronchospasm and hypersensitivity, otherwise categorized as NSAID allergy. In the pediatric population, there is a concern for Ray's syndrome, Stevens-Johnson syndrome, and you do have to take special consideration in pregnant and lactating women. Now, looking at the cardiac side effects a little bit closely. So NSAIDs as a whole class has been associated with increased risk for myocardial infarctions, congested heart failure, hypertension, and stroke. It's really unclear what the mechanism is. There's belief that there's platelet aggregation and vasoconstriction involved in this, but not conclusive evidence. The other thing that's been clear is that the higher the dose, the longer the duration, the greater the risk. And although there's been no head-to-head trials, in naproxen trials, it's shown to be less cardiotoxic. Now, the COX-2 inhibitors, which are celecoxib and rofecoxib, are COX-2 selective inhibitors. So they've been shown to cause significantly fewer adverse gastrointestinal effects. Rofecoxib voluntarily withdrew its medication from the market due to increased risk of myocardial infarctions and stroke. And back then, it was believed it was just the COX-2 inhibitors. Since then, we've known that it's a class effect. So what about celecoxib? It's still on the market. Does it pose an increased risk compared to all the other opioids that have a class effect of increased cardiovascular risk? So I would probably say that if there's a risk of cardiotoxicity, I would stay away from celecoxib. Now, the FDA label warning currently and previously was brief, and I've listed it here in quotations. The risk of heart attack or stroke may increase if you use more than directed or for longer than directed. So again, there is evidence that the higher the dose, the longer duration, the higher your risk. Well, the new FDA warning that is to be seen on new manufactured bottles is going to have a lot more detail in it. And the amount of detail that they've gotten with the new evidence is that, yes, the longer you take it, the more you take it, you will have an increased risk. But you may have a risk, just a general risk, even in the first weeks of NSAID use. It's not clear if all the NSAIDs have a similar risk. Now, again, this points to naproxen, which has asked for a cardioprotectant labeling, which the FDA has said no. They'd like to see head-to-head trials showing this cardio or less cardiotoxic effects compared to the other NSAIDs. And the new labeling will also emphasize that you can have cardiotoxicity even if you don't have a high risk factor for having heart disease or heart risk factors. What we do know, though, is that the risk increases, of course, if you've had a previous MI. Then if you continue opioids, then you're more likely to have another MI and potentially it causing morbidity and mortality. And there's a risk of heart failure with all NSAID therapy. So I know this is a lot of detail, which is going to be on the new labeling, but pretty much the concern for cardiotoxicity is real. You want to be cautious on who you started and how you monitor for these risks. So we're going to talk about an IV NSAID, Ketorolac, which is also one of the most potent NSAIDs. It's available in IV, IM, and oral route. Its onset of efficacy is comparable to that of morphine IV, so very potent. Now, Ketorolac, its positive is it doesn't have all the opioid side effects. Less drowsiness, nausea, vomiting, constipation, all of those. But because it's a potent NSAID, it has a much higher increased risk for GI bleeds and ulcers. So again, the theme is the higher the dose, the longer the treatment, the higher the risk of these GI complications. Ketorolac has only been studied for a total of 5 days because of this increased risk in GI complications. So when you are using ketorolac therapy, you don't want to exceed these 5 days. It also needs to be dose adjusted for renal impairment and elderly. So you usually use half the dose.